and welcome to everybody. So first question, all of the following are suggestive of complex as opposed to simple if we designate a fistula as simple or complex. Which of the following are suggestive of complex except associated abscess, single external opening, associated proctitis, and a transsphincteric fistula? Okay, good. We'll come back to these at the end. This one, there's more than one right answer. I just wanted to get a feel for what people out there are doing. So for complex perianal Crohn's, which is your most frequently recommended treatment option? Seton placement, fibrin glue, oral corticosteroids, immunomodulators, anti-TNFs, or a diverting ileostomy? Again, acknowledging that there's more than one right thing, and this is not a all or none here. Okay, so seton placement and anti-TNFs, and diverting ileostomy comes in third. And then, third question, a patient with complex perianal Crohn's and a perirectal abscess, drainage is performed, 4 setons are placed. To maximize a sustained response, which of the following would you recommend? Keep the setons in, no medical therapy needed. Add an immunomodulator and then assess for removal of setons, add an anti-TNF and then assess for removal of setons, long-term antibiotics and then assess removal of setons, or combination therapy and assess for removal of setons. Okay, so the TNF combo, either TNF alone or TNF combo are winning. Okay. So let's go to our case. This is a gentleman we recently saw. He's now 23 years old. He was diagnosed with Crohn's disease in 2002 at the age of 13. He initially was, this is our second case of mesalamine treatment after Dr. McDermott told us not to use mesalamine, but treated with mesalamine, and he had a mild course initially. In 2005, he had increasing symptoms and then developed a perforation. Underwent a resection of the ileum, part of the right colon, with a diverting ileostomy, and 5 months later had closure of that ileostomy. He was started on 6-MP postoperatively. He's been on it since then, but when we first met him, he admitted to variable adherence with this treatment. And he did well for about 4 years after this. He'd note some intermittent symptoms of blood and abdominal pain, for which his treating gastroenterologist would put him on short courses of budesonide, to which he would respond. Then, in September 2010, so about 4 years after closure of his ileostomy, he presented with a perianal abscess requiring drainage, and the outside operative report describes a horseshoe fistula. And for reasons that are not entirely clear, the next step was to jump into a diverting loop colostomy for the perianal disease. And he noted some partial improvement with this. And importantly, despite having a loop colostomy, he was still passing stool per rectum once per day. So the point here is that he's not completely diverted. He was continued on his 6-MP. No other medical therapy was initiated. He underwent a colonoscopy, which showed some inflammation in the anal canal, mild inflammation and stenosis at his ileocolic anastomosis, and a normal appearing neoterminal ileum. And again, he's based on partial improvement, I guess. He had his colostomy taken down, and not surprisingly, he had worsening perianal disease. So in March 2011, he presents to the Cleveland Clinic for the first time for a second opinion. He is on 6-MP at 75 milligrams per day, ciprofloxacin twice a day, and is now requiring oxycodone because of his perianal pain. He doesn't have much in terms of intestinal symptoms. He's having 1 foreign bowel movement every day, intermittent blood, but he is having dramatic perianal symptoms, and as I said, requiring oxycodone. No belly pain, he's lost some weight, and he has no extra intestinal manifestations. On an exam, when we see him, he's visibly uncomfortable. He can't sit. He has to lay on his left side. It's just too uncomfortable for him to sit. We attempt an anal exam. You can obviously see some fistulas and pus, but can't even part his buttocks to do anything. We do a CT angiography to get a sense of what's going on with his intestinal disease and also to assess for an abscess. You can see here there's a short segment of anastomotic and neo-TI inflammation with mild narrowing. And then pay attention here, it's cut off on my screen, but these are the rectum and 2 fistulas emanating from the rectum, and I'm just going to scroll down as you see those fistulas, and then we're going to jump a little more posteriorly on the coronals, and you can see these fistulas going back posteriorly. These are the cross-sectional images, same kind of thing. You see these fistulas. We have him see a colorectal surgeon that same day. That very next day, he's taken for an exam under anesthesia, where he's described to have a fibrotic anus with a broad-based posterior anal ulcer, and he's got both complex disease on the right side and on the left side. And just as a quick stopping point here, so we make sure we all have the same terminology, 2 general classification systems for perianal fistulas, the Parks classification, a more anatomic description with the, as shown in the images, and then a more simple, for gastroenterologist, classification of simple versus complex fistula. A simple fistula consisting of a single external opening without associated sepsis, stenosis, inflammation, and no connection to the vagina or bladder, and then more simple low-lying fistulas. Okay, so the first question is to our surgeons. You have him in the OR. You've done this exam under anesthesia. What do? Dr. Cohen, as the guest, you want to go first?
Well, I think the principle of treating this man, at least taking him to the operating room and doing an examination under anesthesia, is to drain any sepsis that has not been found on imaging, explore all the fistula tracts, curette them all, and then place seatons in the, which was done, place seatons here, to loose seatons to try to control the situation and at least allow the patient to some quality of life to be able to sit down.
Ravi or Feza, anything else we should be thinking of once we acutely drain and relieve the sepsis?
Not at this stage, no.
What is there a role? Or go ahead, Aaron.
Is there a problem with having a very fibrotic rectum with posterior ulcers and just doing seatons?
I don't know if there's a problem. I mean, this person has a problem, a real problem. A serious problem, and I can, this is the type of individual who's not going to get any better, no matter what you do, and you're going to have to do something more radical for this patient eventually. Is there something wrong with having the seatons in place? No, I don't think so. I mean, it's hard to know. Usually you don't have 4 fistulas and 4 separate internal openings. So the idea really is to find the internal opening, define the anatomy, and usually these are branching off of one. So you have to find the main internal opening, and you can open some of the external openings as well to allow for better drainage, but I think that what I've described before is what I would do.
What about, is there a role, would you rethink about diverting him? So he had a kind of an unsuccessful, incomplete diversion before.
I was thinking of more aggressive.
Yeah. Well, I think that this patient will come to either ileostomy or likely a proctectomy eventually. I do think so, but I don't know that you have to do that initially. I think if you drain the sepsis and put in the seatons so that nothing else builds up, you may be able to keep this patient comfortable for a while.
I think the critical thing here, what I learned the hard way, is not to impose somebody to have an ileostomy or colostomy unless they made an internal resolution or peace with themselves. So yes, we can give the likelihood, the fact that they're going to need an ileostomy or colostomy at one point, but I think they will come when they're ready. I think that communication line is very important. I think this is the importance of the privilege of taking patients with IBD. It's a lifelong relationship to establish that, so they don't feel like they're being tricked, and being transparent about the things, and they're part of the decision making, because there's no major rush.
Okay.
Yeah, I think that this is a very good presentation, and it's a complicated case that we often see. A lot of the patients that we see with Crohn's disease have many issues that bother them chronically. And one of the things I tell them, I ask them if they ever seen those World War II movies where all the soldiers are coming out of battle and they all look beat up as can be, and then they get sent right back in. And many of our Crohn's patients are walking wounded in many ways. And we'll see these patients, like you're describing, who, and just as Dr. Cohen said, can't sit down. And that's how you kind of know how well they're doing. And so the issue is, how much can the patient put up with? Well, if any of us in this room had even one of those fistulae, we'd be yelling and screaming and running to the operating room right away. And our patients have 4 or 5 chronically. So they're putting up with tremendous pain. And so our job becomes, how can we help them without hurting them? So I agree with certainly the seatons, and many of our patients will have multiple seatons wrapped in and around their anal region. I think we usually try antibiotics. I'm not sure antibiotics help a lot, but they might help a little bit. And then theoretically, the origin of these fistulae and abscesses is Crohn's disease that's active in the anal rectal area that's feeding them. And so I think that we do use anti-TNFs. Usually these patients take high dose anti-TNFs, so I'll often wind up at 10 milligrams per kilogram fairly frequently, maybe every 6 weeks or so if it's infliximab, or I'll wind up at 40 milligrams weekly if it's adalimumab. And often the anti-TNFs will partially help. So I think we need to set our goals that, just as Dr. Cohen said, we want our patients to be able to be able to sit down, to be able to work. It's not going to be perfect, but if we add an anti-TNF and biologics, they may still need their pain meds, and I don't think we should withhold pain meds from these patients. And then they can have not an ideal quality of life, but they can hopefully continue working, again, just as our walking wounded do.
Okay. So we're going to get back to some of those topics. So this kid was an easy sell in that he had a prior colostomy. So the cell, when we saw him, we were skeptical that starting medical therapy right now was going to by itself do the trick for this kid. So what we had talked to him ahead of time was to be ready about to do a true defunctioning stoma, which he had not had before. So after the EUA, he underwent placement of 4 seatons. The surgeon was impressed with that narrowing at the anastomosis. He had a laparoscopic stricturoplasty and a defunctioning loop ileostomy. This is not him, but we didn't take a picture of him, but this would be similar to what his bottom looked like when the surgeon was done with him. Okay, so the idea here was to temporize until we could move ahead with further medical therapy. He was certainly open to the idea of a temporary stoma, and again, because he had had one stoma already, it wasn't that hard of a sell for this kid. But obviously he was very clear that he didn't want this as a long-term or permanent type thing.
What did the rectum look like?
I'm sorry?
At the colonoscopy, what's the colon and the rectum?
The anal canal is inflamed, the rectum is not inflamed.
How about the rest of the colon?
Colon is fine otherwise. So, Dr. McDermott, or Aaron, what is, you started hinting at here, the TNF therapy, how likely is TNF therapy to be successful? And is this a kid we should be thinking about combination therapy in?
Well, I think that the most important thing has been done, which is drain the sepsis. And I think that...
When's that bag going to be taken away, Dr. Brzezinski?
Yeah, I would start a patient like this with anti-TNF alpha. And the question is whether it should be with azathioprine or without. And being a young man, one could question the risk of hepatosplenic lymphoma. I think that I would still start him on dual therapy. We know that he's tolerated azathioprine in the past. What I don't know is which dose of azathioprine, but I would start anti-TNF alpha.
Aaron, yes, Aaron, do you want to start a TNF therapy 4 weeks after seton placement? 1 week? What's the time of safety zone?
As soon as the surgeon tells me that the risk of intra-abdominal abscess is gone, which is usually by 1 or 2 weeks, I think that this patient has an ileostomy. A risk of post-surgery, even though the patient had lost weight and was immunosuppressed when he went to surgery, I think that the risk of major complications is not huge. So I will, as soon as the surgeon feels comfortable, I think that I would start it.
Do you feel like the TNF-alpha would affect wound healing, especially ileostomy on that side, immediately after surgery? Do we have any concern for that?
Which wound, the ileostomy or the perianal?
Ileostomy.
Ileostomy.
The real issue, I think, here is recrudescence of sepsis in the perineum. So we've got to be reasonably confident that all the abscess and any sepsis has been drained. I think the abdominal wound healing and the ileostomy is not so much of an issue.
Okay, so Dr. McDermott, he's been on 6-MP for 4 years, and now we're advocating combination therapy. What are you going to tell him about his lymphoma risk?
Well, I think as everyone knows here, the real lymphoma risk is with 6-MP or azathioprine. And so the risk of 6-MP azathioprine has best been shown with the Colostomy study from France, and it's very clearly 3- or 4-fold. Our patients get many different kinds of lymphomas. The young people, if they get infectious mono, can then get an EBV-driven B-cell lymphoma. Our patients can get a lymphoma similar to what transplant recipients get, who are immunocompromised, and so the lymphoma risk is actually with the 6-MP. It's not with the anti-TNF.
What about hepatosplenic T-cell lymphoma?
Yeah, I mean, hepatosplenic T-cell lymphoma is the same, although it was originally described in the combination therapy group. The vast majority of those are also with, predominantly with the immunomodulators, the thiopurines. So that, in this particular patient, we're going to have to treat, we're going to have to do something after the extensive drainage that's been done, and hopefully the patient will improve. And so the issue is not treating, because what's really treating the patient is that they're diverted. And so the patient's going to get better because they're diverted. The reason to consider an anti-TNF is if the patient wants to be put back into continuity because they don't like the ostomy. In other words, are we going to put back that fecal stream which drives this whole process? And so if the patient refuses to have a long-term ostomy and you're going to put it back in, you've got to treat this situation so that hopefully you can prevent the severe recurrence of the disease when you put it back in continuity. And, the risk of lymphoma is very low. And so you could either do it with anti-TNF alone, or you could use it. I would do combination therapy. And then usually what we do is, if someone's on 6-MP or azathioprine, we add the anti-TNF after they've been on combination therapy for 6 months. Then we either taper the immunomodulator down to 1 pill a day and or gradually get rid of it by the time you're a year out. So you get the benefit of the combination therapy early on. And there've been a number of studies that show that. And so I'd probably consider that approach, continue the patient on the anti-TNF. The issue comes with getting rid of the surgeon's excellent work and putting that in that ostomy and going back to in continuity.
We're going to come to that, so if I could stop you there, Dr. Cohn.
I agree with you, and I just want to emphasize the way in which these things happen to a patient. This patient had a stoma. It was not functioning well, so the patient did not have a good experience with it. And the fecal stream wasn't completely diverted, so the pain in the anal rectal area continued. So it is really extremely important for the surgeon to construct an ileostomy that is going to defunction the area. And a loop ileostomy usually will do that, but sometimes there is overflow into the distal limb, and if you really want to be sure, you can bring up both limbs, both sides in the same stomal opening as an end loop, so you've completely diverted the area. And I think what happens in my experience with a lot of these patients is that if you give them a very good quality of life with a properly functioning stoma, over time they will realize that they are going to have a better long-term outcome with a permanent stoma than trying to close it again. And they will come to that conclusion themselves.
And that's the key, isn't it, for these ileostomies? It's more of a bridge to permanent, the itself.
So let me move on because we're going to hit some of these in a second here. So we talked to him. We decided to go with dual therapy, so he was kept on his long-term 6-MP, and we added infliximab on top of it. He noted, immediate improvement, likely due to the defunctioning ileostomy, but there was also an incremental benefit. There was about a 6-week delay before he started his infliximab, and there was kind of further improvement after he went on the infliximab. Continued to have no significant GI or intestinal symptoms, and we're now, let's say, 6 months out from that, and he's harping, he's not ready to live with his ileostomy permanently, so what do we do next? He's on therapy, things are better. Do we start removing the seatons first? Do we close the ileostomy first? How do we approach things from here? So the surgeons.
From my point of view, you do not remove the seatons because you're going to need those, but I'll leave that up to the surgeons.
Okay.
Robert?
He's at a very high risk for recurrence of his perianal Crohn's when the ostomy is closed. I think he needs to have his anorectum assessed and see if the inflammation is better. I think this would be the opportunity because this patient is adamant about not having a permanent ostomy, this would be the time to remove the seton and see if the fistula closed. Because if they did, this is going to be like a delaying game, but I would expect that the fistula won't close, and that's how you end up convincing the patient that maybe a permanent ostomy would be the way to go. If the fistula did heal, though, and they stayed that way, and if the patient's very adamant about having the ostomy closed, it's worth trying, but you need to really, really spend a lot of time with the patient, counseling him that the whole sequence of events may unfold once the fecal stream's back in circuit.
So this is the debate we had. You remove the setons first as kind of a test before you close the ileostomy, or you need the setons, keep them in, and close the ileostomy first.
So I would say if you had one fistula, I'd be okay with you removing the setons. But you've got 4 fistulae here. And when we give an anti-TNF to patients who've got multi-pararectal fistula, maybe 1 out of the 4 will heal. Maybe 2 will get partially better, and 1 may not respond at all. In addition, you've got a horseshoe abscess in there. So that's why I would leave the setons in. So at least you're not blindsided by that, because the question is, once you close that ileostomy, that's the big deal. Will your anti-TNF hold once the fecal stream is back in sight? So I would say if the patient isn't bothered by the setons, and most of them really don't know that they're not complaining about it, I don't think there's any reason to remove it because it's going to help you. It's not going to hurt you to have those setons in.
I think the critical thing is, I would just go ahead and close and see what happens after the examination. Leave the setons. The critical thing is, the immunomodulators here is not helping for the fistulas to heal completely. It is allowing for the things to get going so it doesn't become more active. So it's more of a complementing and supplementing each other, the presence of a seton and immunomodulator. That's at least I would do. I don't know what you guys did.
Yeah,
Well, I would go halfway here, and I think from what I saw from the slide, there were a couple of fistula that were in communication with the main tract. I would attempt to remove those setons, but the one that's controlling the main internal fistula, the seton that's controlling the main internal fistula, I would not remove. And I wouldn't even want to close his ileostomy. I'd give him some time before doing that. But if he absolutely insisted, that he wanted to try to have the ileostomy closed, then I would leave that one seton in and close the ileostomy.
Okay. So we actually, not by choice, but one seton fell out on its own. The other one was irritating and was removed. So we took 2 out, we left 2 in. So this is now a year later. He's feeling well. We're down to 2 setons. March 2011 was his diverting ileostomy. March 2012, he was taken back to the OR with continued medical therapy and nervous closure of the loop ileostomy and 2 seatons kept in place. We had a little scare. He showed up about 3 weeks post-op with some pain and irritation near a seton. There was a small abscess that was drained. And then as of a week ago, so that's now 2 months ago, and as of a week ago, he's doing fine. He remains on continued 6-MP and infliximab, and he still has his 2 seatons in. Okay? So 2 questions. Let me go back to the gastroenterologist first. So what do we do with his medications now?
Well, I don't know with the medications, but next year is a good case to present to see what happened.
Yeah.
No, the medications I would continue. I think that the patient has been already on dual therapy for enough time. I don't know that there's going to be there's no clear evidence that ongoing treatment with a dual therapy will do much else for what's been done. I think that I would stop the azathioprine. I would continue anti-TNF-alpha and see how he does.
Yeah, I would agree. After a year, I would continue the anti-TNF and consider decreasing the immunomodulator as much as possible. Part of this is going to be what will the patient be able to tolerate and how much can the patient put up with. If he develops another small abscess on the anti-TNF, that can be handled by drainage in addition to antibiotics, et cetera. And, hopefully the patient will do well for a while. I think that we have our goals, but the patient has the patient's goals. And one of my patients, favorite patients, did beautifully with a diverting ileostomy and was getting married. And she said, I am not walking down the aisle with an ostomy. And then, all her perirectal disease came back. So that there are also patient issues that come into play a lot with these issues.
Okay. And then so far so good, only 2 months after closure. But surgeons, how would you answer the first question? Is this kid likely going to need permanent diversion at some point?
I would say yes.
Maybe.
Maybe. Feza, you got no? Can I get a no from you?
I think so too. But again, less is more. Let's see what happens.
Okay, so a couple just wrap-up slides. So, I think we heard it here, but if you look at the American Society of Colorectal Surgeons practice parameters, in quotation marks, primary treatment for perianal Crohn's fistulas is medical. Surgery is reserved for the complete control of sepsis and occasionally as an adjunct for cure. Dr. Ramsey had this slide, and I emphasize here that about 10 to 15% of people will require permanent diversion. And just as a reminder from a medical standpoint that really the only drug for which we have great evidence-based efficacy in perianal fistulizing disease, for which there was a primary endpoint study, is infliximab with the ACCENT-2 study showing benefit. And I'll skip over that. And so let's go over these briefly. I think most of you had them right up front. But so which of the following distinguishes a complex fistula from a simple perianal fistula? Let's vote quickly. So it's all of which except, sorry, I don't want to confuse you. All the following suggest complex except. Good. So single external opening, I think we had some improvement pre to post on that one. Let's quickly vote on this one again. So let's see whether people's votes changed at all. So complex perianal disease, again, acknowledging that more than one of these things are needed. Which do you most frequently recommend? Okay. So as we saw, basically those are the things. The important point here is in complex fistulizing disease, fibrin glue injection has no role, nor do oral corticosteroids. Immunomodulators, perhaps in conjunction, but not by themselves.
But I think that an important point is that you don't start immunomodulators before you do drain sepsis.
Sure. I'll always drain the sepsis first. And then this was, this kid, and we won't vote on this one, but most of you had voted either for anti-TNF alone or combination treatment, which is, I think, the appropriate debate here. So thank you.